Good evening, everyone. I'm Clifford Young, your current class treasurer and a friend of our speaker today. On behalf of the class of 1988 officers, it's great to see so many classmates here tonight. We're glad you could join us for this talk and the class social to follow. It's a pleasure to introduce tonight's speaker, Dr. James Gill, MIT 1988, Course 7. Jim lived in McGregor House, F entry. Jim earned his medical degree at the University of Connecticut, followed by an anatomic pathology residency at Yale, and then fellowship in oncological pathology at Memorial Sloan Kettering Cancer Center, and then forensic pathology fellowship at the New York City Office of the Chief Medical Examiner. Jim is currently the Chief Medical Examiner of the state of Connecticut, and previously served as Deputy Chief Medical Examiner for Bronx County. He is past president of the National Association of Medical Examiners, past chair of the Forensic Pathology Committee of the College of American Pathologists, and a fellow of the American Academy of Forensic Sciences. Over the course of his career, Jim has testified in more than 450 criminal and civil cases, has authored 2 textbooks, and has authored over 140 scientific articles and book chapters. His work combines medicine, law, and public health, with particular focus on drug intoxication deaths, medical therapy complication deaths, infectious disease deaths, and the often overlooked but critically important science of death certification. His experience also includes the mass fatality response and victim identification following the September 11th attacks. Tonight's talk isn't about television forensics and courtroom drama. It's about how real science is applied when the stakes are high, the facts are incomplete, and the consequences matter deeply for families, courts, and public health. Before we begin, just a quick note on logistics. During Jim's presentation, please mute your microphone so we can all hear Jim's talk clearly. Please place your questions in the chat for the Q&A afterwards. In the Q&A, for some questions, we may invite the person to ask the question live. Later, we will transition to the class social breakout rooms for informal conversation. Jim, on behalf of our classmates, thank you for being our speaker. We look forward to this topic.
Thank you. So I think we're all old enough to remember Dr. Quincy. He was the television forensic pathologist. And hopefully we'll all get the joke that he's sitting at a microscope, but he's holding a Kodachrome slide. I never had a chance to meet him or any of the better looking ones that came along since him on television. But I did meet one famous forensic person, and that was a man who played the coroner in The Wizard of Oz. He was in New York City signing his book, and he was nice enough to sign a copy for me. So tonight we're going to be talking, I'm going to give you a little overview of the medical examiner system. We'll talk about forensic pathology and tech, and we'll go through the World Trade Center disaster, some public health issues, and then we'll finish up a little bit with the autopsy. There are going to be a couple slides in here. They're close-ups, so really shouldn't be anything horrific. But I just want to give a little warning just in case. So as Cliff said, we were both residents in McGregor House. I was in F entry, and I was between my first and second year of at MIT, between my freshman and sophomore year, that I spent the summer at the crime lab in Connecticut with Henry Lee, and I worked in their serology section. This was even before DNA was really being used in forensics. And that's kind of where I got my start in forensic pathology. I ended up working many years at the New York City office, and this is the chief office in Manhattan. It's on the corner of First Avenue and 30th Street. And if you go in the lobby, there's a Latin inscription, and it translates as, "Let conversation cease, let laughter flee. This is the place where death delights to help the living." And we really do think of our work as actually helping the living. So the forensic sciences can be broken down into forensic medicine, which would be my area, forensic biology, the DNA folks, forensic toxicology, and then all the criminalists, the firearms examiners. Essentially, you could pretty much take any profession and put the word forensics in front of it, and if you're applying it to a legal matter, it works. So forensic pathology is a subspecialty of pathology where we examine actually both the living and the dead, mostly the dead in this country, to give an opinion about the cause, mechanism, or manner of a disease, injury, or death. And in the United States, there are only about 800 or so full-time practicing forensic pathologists. There's quite a shortage, actually, and we need probably double that number. But you can see after college and medical school, you need to do 3 or 4 years of residency in pathology, and then a year fellowship in forensic pathology, and pass 2 national board examinations to become board certified in forensic pathology. Now, medicine to produce health has to examine disease, and that's something that we do at the medical examiner's office. We like to say that death certificates save lives. And if you want to improve the lives of your citizens, you have to have a compelling interest in their deaths. In order to prevent deaths, you want to know why they're dying. And that's a big function of our work. Now, in the United States, there are 2 types of death investigation systems. There's a medical examiner system and the coroner. The main difference is that coroners are typically elected officials, and they may not be physicians. They may be a funeral director, yet they're in charge with investigating and certifying the death. Medical examiners are typically forensic pathologists, and they're usually appointed by some government body. I think there are pluses and minuses for both of those systems. And I think the problem comes in when it's not properly funded or staffed. So by statute, there are certain deaths in each jurisdiction in the country that have to be reported to the medical examiner or coroner. And these include all unnatural deaths, accidents, suicides, homicides, drug-related deaths, diseases with a potential public health threat like meningitis or tuberculosis, deaths resulting from employment, unexpected deaths, deaths related to medical complications, and deaths that occur in police custody. These vary a little bit from jurisdiction to jurisdiction, but these are the most common ones. So what do? Well, we certify the cause and manner of death. We make sure we have the right name on the death certificate. We testify in homicide, sometimes civil cases. We have a public health role. We teach. We sometimes examine the living, very rarely. And then we help families get through a very difficult time of their life. So Mark Twain, who actually had a house in Connecticut right down the street from our office in West Hartford, said that there are 3 kinds of lies. There are lies, damn lies, and statistics. So I'm just going to share with you a couple statistics, despite what he said. So Connecticut has a population of about 3.6 million. About 33,000 people die a year in Connecticut, and we investigate in some way about 2/3 of those. We certify about 5,000 and perform autopsies on about 2,800. So let's talk about death certification. This is the death certificate, and you can see there's a place for the cause of death, contributing conditions, and then the manner of death. And a lot of people confuse these 2 terms, manner of death versus the cause of death. Now, the cause of death is the disease and/or injury responsible for the death. It could be a gunshot wound, it could be acute fentanyl intoxication, it could be lung cancer. And we have a special term called the proximate cause. And that's the disease that in a natural and continuous sequence, unbroken by any efficient intervening cause, produces a death and without which the end result would not have occurred. And it must be an etiologically specific disease. The manner of death, on the other hand, is an explanation of how the cause arose, and it's based on the circumstances, and there's only a handful of choices. It's either natural death or an unnatural death, homicide, suicide, accident, or undetermined. Now, sometimes we'll see cardiopulmonary arrest as a cause of death. Cardiopulmonary arrest simply means that your heart and lungs have stopped. It's not a cause of death. It's a synonym for death, but we still see this, believe it or not, on actual death certificates. So whenever you read this in the newspaper that a person died of cardiopulmonary arrest, they really don't know what they're talking about. Now, the questions we want to ask when we have an investigation is, who are you? When and where did you die? Why did you die? The autopsy is going to help us with that. What happened? We may be able to give an opinion about the range of fire, for example, in a gunshot wound death. Who did it? That's rarely a question that we can answer. That's really a question for the police and prosecutors and witnesses and so forth. Sometimes the question is, what is it? Someone found a bag of spaghetti and meatballs in a garbage can in a bathroom at Macy's. They called the police. The police came and they thought it may have been a fetus and a placenta. So are you going to call? You call the medical examiner. We go there, examine it, and say, nope, this was somebody's lunch. It's not nothing to worry about. But the reason why identification is so important is highlighted by these two young ladies. This was a van of college students in the Midwest that crashed. And one of these ladies died and the other one survived in a coma. And initially they were misidentified by the coroner. So you can imagine the family. Initially, one family thought their daughter survived and the other family thought their daughter died. And then it was actually the reverse. So let's talk a little bit about forensic pathology and tech. And we're going to go through some molecular toxicology and some imaging areas. We're going to talk about hearts that are too good to die. And this, of course, relates to course 7. And we're talking about DNA. And initially in forensics, DNA was largely used for identification, right? You wanted to find out who that blood drop belonged to or who that person was. But now it's being used in diagnosis as well. It's been in the news a bit, forensic investigative genetic genealogy with Savannah Guthrie's missing mother, in that they've recovered some DNA there. If there's enough DNA to do this investigative genetic genealogy, they may be able to identify the person who left that DNA. They initially tried in CODIS, which is a large database in the country of criminal offenders and so forth, but it doesn't have everybody. So by doing this, they may be able to go back and create a genetic family tree and then narrow it down to the person whose that DNA belongs to. And this is one of the examples, one of the profiles that we received in a case that we used it for to make an identification of an unidentified decedent. But it was also used in the Idaho case of the 4 college students that were stabbed to death. This is how the perpetrator was identified. They found some of his DNA at the scene, and then he wasn't in the CODIS system, so they ended up using this FIG technology to build a family tree, and one of his family members was in GEDmatch Pro, and they were able to work their way back and identify him. But we use it now for genetic heart disease, and we can see them in 2 flavors. One is electrical diseases, and the other are cardiomyopathies, which we can actually see at the autopsy table because the heart is usually enlarged and abnormal. But these electrical ones, the heart can actually look normal, grossly and microscopically. And what we're talking about are mutations in these channels in the myocyte, sodium, potassium, and calcium channels, that can, by this mutation, cause irregular rhythms in the heart. And the 3 major ones we talk about are long and short QT syndrome, Brugada syndrome, and then CPVT. And so these mutations can cause the heart to go into an irregular rhythm, a fatal irregular rhythm. Here's an example of kind of a long QT workup and the genetic profile. And they're looking for these mutations that are known to be associated with this disease. And it's been said that these channelopathies are the ideal arrhythmogenic assassins because you really can't diagnose them at the autopsy table or under the microscope. You need to do molecular testing in order to find them. What about toxicology? We'll get into some course 5 and course 10 here. We probably all hopefully remember our professors from freshman year, Dr. Wrighton and Kemp, and then Sharpless, who won 2 Nobel Prizes. Kemp wrote this organic chemistry book, and I think it was Professor Wrighton, who ended up with freehand just kind of filling in the periodic table on the chalkboard, and we all kind of clapped when he did that from his memory. So forensic toxicology, we see quite a bit of drug abuse and alcohol use at the medical examiner's office. We see things like this, which are track marks. This is a woman who's been injecting drugs in her legs for years, and they get these linear scars. Now, I'm sure you've all heard of the opioid crisis, and I'm just going to give you a little bit of more statistics from the Connecticut office. I want you to look at this line in the fentanyl and any death. So these are all accidental drug intoxication deaths that occurred in Connecticut. And you can see in 2013, 37 people died from fentanyl intoxications. If you go out to 2022, over 1,200. And now we're seeing a decrease again. And so fentanyl, hopefully, and I think some of the national statistics bear this out as well, you can see synthetic opioids, which is essentially fentanyl, this gray line, how it's peaked in 21, 22, and now it's starting to decrease. methamphetamine and cocaine, which are the yellow line. Sorry, methamphetamine is the yellow line, and cocaine is the orange line. Both of those have been increasing as well. So we send out our samples to a private laboratory, and they have multiple of these high-end machines, the Gastro GC mass spec. And what they can do is they can put the sample into the machine, and the drugs get broken down into different fragments, and they come off the column at different times, and you can get a kind of a fingerprint type profile of what the drug is. And so, for example, this is cocaine. Now, one of my friends was watching one of these TV shows, one of the CSI shows, and they were talking about how they were going to do toxicology testing, but the person was so badly decomposed or skeletonized, they couldn't get any tissue, so they were going to test the maggots for the toxicology. And you can actually do it because the maggots eat the tissue, and so any drugs that are in the tissue are going to get inside the maggot. Unfortunately, the next scene, they show them dissecting a single maggot. And I can tell you that that's not how it's done. I won't get into details, but it involves a lot of maggots and a blender. Now, the opioid receptor is what we're interested in with the opioid drugs. And you can see fentanyl, oxycodone, heroin, which gets broken down to morphine. All of these are going to act on that opioid receptor. But some of these drugs are much more potent than other ones. So you can see these are kind of equivalent doses of heroin, fentanyl, and carfentanil. And you can see how little amount of fentanyl or carfentanil is needed to actually cause a death. And that's one of the reasons why fentanyl became such a problem, is because it was very difficult to dose. We're not dealing with chemists or pharmacists here. We're dealing with, drug suppliers, and they're mixing these chemicals and powders, and they don't get the mix exactly right. And all of a sudden you have a very potent dose. What they also started to do was starting to add little different subgroups onto the fentanyl structure to make it a different type of fentanyl. And these made it more difficult for us to detect in the toxicology lab. I couldn't leave out economics and management here, so I'll talk a little bit about the economy of fentanyl. And another reason why it became so popular was because it's cheaper to make than heroin. You can make it in a lab. You don't need to grow the poppy and then chemically treat it to become heroin. It's easier to transport because it's more concentrated. You don't need to transport as much, and you need smaller doses. And so that's one of the reasons, I think the major reason why it did become more popular. There's no FDA on the street, so you never know what drug you're going to come across or find in that little drug packet. And again, this is just an indication of carfentanil, how little carfentanil is enough to cause death. There are other types of poisoning too, which typically we're seeing with suicides. And this was there was a car parked outside of Home Depot, and in the car was a person dead in the front seat. And you can see him here sitting in the front seat, and he had a bucket here with some chemicals. Whenever we see that, we kind of tell our investigators to step back, call a hazmat team, don't go near the car, because there are these different types of chemical asphyxias. And I'm going to give you a little trigger warning here, not because it's something really gross, but because it's a chemical formula. And anyone who's had some more, organic chemistry flashbacks or chemistry flashbacks, I didn't want you to get too upset. But what happens is if you mix sulfuric acid and formic acid, you can create carbon monoxide, and it can cause death, just as you have with smoke inhalation. Course 12, we're getting a little bit of imaging. And I have to say, Cliff actually has been a consultant for us at the medical examiner's office. When we have, we have a question fracture or something on one of our x-rays, he's been kind enough to look at those images for us. But we use them largely for comparison. Here we can see if we have a person we're not sure who they are, if we can get a known radiograph and we can compare it to the radiograph we take at autopsy, we can make that diagnosis and that identification. We also use it for people who died of gunshot wounds, looking for where the bullet is in the body. And you can see some radio opaque material here. This is a bullet, and there's some other fragmented things here, which we can see here and here. And we're going to make sure at autopsy that we recover these, because this may be important evidence. And we recover the bullet, but along with the bullet, there are also these two other little fragments of metal. I'm like, what the heck are these? And so we look at the clothing, and this is the clothing that the person was wearing when they were shot. And here's the bullet hole in the clothing. And if you look at the clothing, these were Levi Strauss jeans, and they have these rivets. And one of the rivets should have been here, but it's missing. And you can see on the rivet, LSF Strauss Company. And this is what it looks like on the back, LS and Company, San Francisco. And that's what we actually recovered in the body. The bullet, you can see the nose of the bullet was deformed by the rivet and even left a little impression of the rivet, and it carried the rivet inside the body. The other time we'll see projectiles are in shotguns, and these are the pellets that we'd see with multiple shotgun injuries. And we don't need to collect all of the pellets. We just need to get some representative ones. But imaging has really become high tech, and a lot of offices now have their own CAT scanners. We haven't gotten ours yet. We're hoping to get it soon. But you can see subdurals, you can see fractures in pedestrians. Here's a person who's stabbed in the head with a knife, and you can see the knife actually is still in there. In abusive pediatric head injury cases, you can do a kind of a 3D reconstruction to see where the fractures are. You can see some intracranial hemorrhage here as well. Now, when I was working in the Manhattan office, I was working one day, and it was a kind of a quiet day. There were only 3 autopsies that day. And I was doing one of them, and it was a man who committed suicide by gunshot wound. But if you look at this little schedule for the day, this happened on 9/11/2001. And we all remember that day is when 2 planes struck the World Trade Centers. And so all of those decedents were coming to our office in Manhattan. We didn't perform autopsies on any of them because most of them were fragmented remains. And the real issue there was identification. We wanted to find out who these people were. And initially, there were estimates of over 20,000 people. It was a very difficult recovery, slow operation, a lot of DNA degradation. There were fires burning there for weeks. And we knew going into it that some remains were not going to be identified. And there were over 400 members of service, that would be firemen and police, who died in that disaster as well. So this started with 2 planes leaving from Boston. They both crashed into the north and the south towers of the World Trade Center. So for the events, we have the airplanes, we have the towers, the collisions, and the collapse. So the airplanes, there's American Airlines with 81 passengers, 11 crew, and the United Airlines, 56 passengers and 6 crew. We're getting a little course 16 here. The airplanes were Boeing 767s, 132 tons, 10,000 gallons of fuel, and traveling at about 500 miles per hour, they carry about 3 billion joules of energy at impact. So here are the World Trade Centers. We'll get into course 1, 2, 3, 4, 11, and 18. The towers, 110 floors, 55,000 workers on an average day. There's a 4 subway line transportation hub below them and 6 basement levels that had stores and plazas. So the North Tower was hit by the American Airlines flight between the 94th and 98th floors, traveling between 429, 495 miles per hour. At 8:46 a.m., it collapsed 102 minutes later. The South Tower was struck by United Airlines at a little lower floor, 78th and 84th floors, at 9:58. At 9:03, and it collapsed at 9:58, 55 minutes after the impact. So the United Air, and the reason why there was a difference in these collapses, and I'll show you some of the studies, United Airlines was going about 100 miles per hour faster than the American Airlines flight, which translates into much more kinetic energy. Plus, it also hit lower in the towers. So NIST, National Institute of Standards and Technology, did a large review of this, looking at the impact sites, reconstructing what was exactly struck in the building, as far as structurally, what was damaged. And again, you can see the South Tower and the North Tower. And the South Tower, although again it was struck lower, and because of that more load above the impact site, it collapsed before the North Tower did. But because it was struck second, more people were able to get out before it collapsed. The perimeter and core steel beams at 1100 degrees Fahrenheit, the steel beams lose about 50% of their strength. And the fires were jet fuel, and it was burning at 2000 degrees Fahrenheit. So again, structurally, you can see the central core and the outer perimeter were damaged enough that eventually that load caused the buildings to collapse. Initially reported missing, again, about 20,000. It turned out to be about 2,753 people. Those towers were reduced to 70-foot hill, spread over 16 acres. There were over 21,000 individual remains recovered, and the excavation wasn't completed until May of 2002. So initially there was recovery, and then after that, when we realized that there are no more living people there, then we go in and try and recover the remains. We had 16 refrigerated tractor trailers at the medical examiner's office to store the remains, and we converted kind of a loading dock area as a temporary autopsy or examination facility to review all those remains. Most the methods of identification included personal recognition, fingerprints, dental comparison, DNA, x-rays, and unique marks or items. For example, this was a man who had a tattoo of Yosemite Sam, and families filled out these forms listing tattoos and scars and so forth. And so we're able to make one identification through this tattoo. The dentists came in and they did dental comparisons. We took DNA if we could and looked for DNA comparisons that way. But DNA really became the way that most of the identifications were done. And we needed to either get something to compare it to. So we'd ask the families to bring us a toothbrush or a razor or something from the decedent. Or we could do a reverse paternity test with parents and siblings that way. And there's a kind of a phased DNA that was done where initially we may not have gotten full profiles, so we would do different techniques in order to try and build up enough statistics in order to make that identification. Ultimately, there were 2,753 people missing and dead. 60% had been identified, and there's still every now and then a new identification will come out. All of the bony remains that could not be identified have been kept. And if future technology for DNA testing comes along, they can be retested. But you can see there were very few whole bodies that were recovered. But without the DNA testing, a third of the decedents would not have been identified. They were responsible for over half of the identifications. Let me go into a little bit about public health. So we identify things like meningitis. You can imagine if a student at MIT maybe had died from meningitis, we'd want to know what that infection was, so other suite mates and classmates who may be at risk can be monitored or treated. There was a defective crib that was marketed where the side panel could pop out and infants could slide down and die from compression. We identified one of those actually in the Bronx, and that led to the recall of these cribs in the country. So again, a way to kind of help the living, right? OSHA deaths, people who died at construction sites, those are going to be reported to our office. And all of the unexpected pediatric deaths come through our office. And so we can play a role in fatality review investigations, looking at babies that are lost to unsafe sleep or to youth suicide, and provide some of that information to the public. Of course, 1, 2, and 8, the laws of motion, also play a role in our motor vehicle deaths and our firearm injury deaths. So all of the motor vehicle collision deaths that occur in Connecticut are going to come to our office, and the Department of Transportation is looking at them from a civil engineering standpoint. Should we put in a traffic light here, or should we do something to change the traffic pattern? We're looking at safety restraint issues in the vehicle. And most of these people that are dying in motor vehicles are from blunt injury. And they're typically dying from lacerations maybe of their aorta or what have you. Now, a laceration, if you were to drop an unripe peach on the floor and it splits open, that's an example of a laceration. And the extent of the wounding is going to depend upon the amount of energy inversely related to the duration of contact and the surface area of contact. And that's been used to great benefit in the improvement in car safety over the decades. Occupant safety systems, what they try and do is prolong that energy transfer of deceleration, right? Increase that T, distribute the force over a broad area, increase that area, the A, and then prevent the person from being ejected from the car. So seat belts will help prevent the person from being ejected from the car, but they also have a certain amount of stretch in them. So they will also help with that deceleration. Because without a seat belt, you're going to end up in the windshield. But now airbags, to me, these are just the ideal scientific thing to decrease this transfer of energy, right? Because what you're doing is you're increasing the time of that deceleration by the body hitting an airbag, and you're distributing that force over a broader area, and so it's going to decrease that injury. And here's an example of that airbag. And of course, same idea with child restraint seats and so forth, so they don't become launched in the car and become a little missile in the motor vehicle. Airplanes also come to our attention. This was a B-17 kind of people were going out and they would go out on like recreational tours, sightseeing and things. And it crashed at Bradley Airport, and we had to autopsy the pilots and the decedents. Let's talk about the autopsy. This is the room where it happens, and we're going to be talking about Course 7, and our 701 teacher was Professor Ingram, and he was actually an expert in sickle cell disease, and he wrote kind of a seminal paper in 1957 on identifying the single mutation that resulted in changing the normal hemoglobin to a sickle hemoglobin. And it took many, many decades for this actually to result in some benefit to the living, but it has now. With gene therapies, they are targeting now this mutation in patients with sickle cell disease. So his discovery led to that. The autopsy, we go through the gross exam with our naked eye, you look at microscopic sections, toxicology, there are a whole series of tests that we do. And the benefits of the autopsy is to establish the cause of death, help in determining the manner of death, produce accurate vital statistics, identify new and changing disease, monitor the public health. We can instruct medical students and physicians, compare premortem and postmortem findings, and assist in legal investigations about what happened. This was a man who actually had a tattoo of the Y-shaped incision on his body, and he said to kind of be gentle. And this is how we remove the brain. We kind of reflect the scalp and then remove the calvarium. These are the types of injuries that we see: blunt, sharp gunshot wounds, chemical, asphyxial, electrical, thermal, and barotrauma. And I'll touch a little bit on each of these and give you some examples. This is a pattern of injury that we see in some people, typically pedestrians, and you can see this is a tread mark from a person who's run over by a motor vehicle. These are pattern injuries caused by a hammer, and you can see the curved part of the hammer, the head of the hammer caused these curved lacerations, and the forked part of the hammer caused the other ones. This is a pattern of injuries that we see in some people who descent from height. So these are open lacerations on the bottom of the feet, and this is from a feet first impact from a descent from height. These are scald burns, and the question is, what happened? If the caregiver tells us that this child was splashed with boiling water from the stove, I would say, no, that's not consistent with this injury. These are typical immersion type injuries. Other injuries, sharp injuries, stabs and cuts. Often the police will come with all the knives in the house and they'll say, Doc, which is the knife that killed him? And we're supposed to look at the wound and tell them. Unfortunately, the wounds can actually be longer than the length of the blade, or the injury on the skin can actually be wider than the width of the blade. So we're not actually that good at saying which is the knife that did it. But when they do bring all those knives to us and say, okay, doc, which is the knife that did it? My answer is usually it's the one with the blood on it. I'm pretty sure that's probably the knife that did it. But what we do is we tell them, don't bring the knife to our office, bring it to the crime lab and do DNA testing on it. Sometimes we may find the knife tip in the body, and that's one of the reasons why we x-ray the bodies. And you can see this little knife tip here in the vertebral body. So if a person's later arrested with a knife, we can say, yep, that's the knife that caused that stab injury. Course 8, we remember our physics lectures, and they did this study with the monkey and the shooting thing, and how the monkey would drop and would hit the monkey. Doc Egerton did this famous photograph of a bullet going through an apple, and this actually demonstrates blowback spatter from the apple. You can see where there's spatter coming out of the exit from the entrance wound of the gunshot wound, and we see that. We may see it on the hands of people who fire a weapon. You can get this back spatter onto the hands. This is a contact gunshot wound. You can see a muzzle impression on the skin. But if it's not contact, you may get some of this other material, what we call fouling and stippling, deposited on the body, because it also comes out along with the bullet. And depending upon how close the muzzle is to the target, you may be able to see some of this, what we call stippling on the body. Here we can see stippling around this entrance wound. So we can say that this is an intermediate range gunshot wound between about 6 and 18 inches away. Here we can see that there's stippling, but something filtered out some of the stippling, and that was his clothing. It was a short sleeve shirt that prevented a lot of the stippling from getting to the skin. So the amount of wounding you're going to see with a firearm is based on the kinetic energy possessed by the bullet, which is going to depend upon the mass of the bullet and the velocity of the bullet, and then how much kinetic energy is lost by the bullet in the body, and what are the tissues that are being wounded. So we remember our famous formula, kinetic energy is 1/2 mv squared. So if you double the mass of the bullet, you double the kinetic energy. But if you double the velocity of the bullet, you quadruple the kinetic energy. So the velocity of the bullet plays a much greater role in the wounding capacity of the firearm. And that's why military rifles cause devastating wounds, because of such a high velocity of that bullet. Course 12, quick one. This is called ferning. This is a pathognomonic finding on the skin. If we see this, the diagnosis is a lightning strike. Very rare, but it does happen. Course 6, I got a little electrical activity here. I'm not sure how you would end up finding a person who's died, but I guess you might be able to figure out a way. And we're getting to Ohm's law. And amperage is really the most important part of electrocutions. Voltage is constant, so therefore we have to kind of think about resistance, and resistance is going to then kind of drive how much current is going to get into that body. And depending upon the amount of amps, milliamps that get into the body, you can cause an irregular arrhythmia of the heart. And this is what an high voltage electrocution burn looks like. They can be very subtle. Low voltage, you may not see anything, so you need to have a high index of suspicion. But you can imagine if you rented this kind of roto-rooter thing to clean out your main drain in your house, and you ended up getting electrocuted by it, you'd want to hopefully make sure that no one else rents that same device, right? And so that's why we have this low threshold for investigating deaths that occur at job sites and so forth. Time of death. What time did he die, doc? And, on the television, we go, oh, 5 hours and 23 minutes ago. Unfortunately, we're not able to do that in real life, but sometimes we can narrow down that time frame, and we try and use a window of death. When were they last known to be alive? When were they found dead? And then we can use things like rigor mortis, livor mortis, algor mortis to try and help us a little bit further. And I'm just about finishing up now, and I'm just going to give you all one quick pop quiz. And you don't need to tell me, but you can just think of it yourself. We have a 43-year-old man. He's a C5, C6 quadriplegic. He's been that way for 20 years. He's admitted to the hospital. He's got terrible decubitus ulcers. They're so deep they've gotten to the bone and caused a bone infection, and the bacteria have gotten into his blood, and he's developed sepsis. and he dies from the sepsis. So what's the cause and the manner of death? What would we put on that death certificate? Well, I'm leaving out a key piece of information. So it's a little bit of a trick question. And that key piece of information is what caused that quadriplegia. And it turns out that he sustained a gunshot wound in the neck in 1984. We bring him in for an autopsy, and we're going to take an x-ray, and we see this little thing in the neck, and that little thing we call a bullet, and we're going to recover that at autopsy. Here we can see his spinal cord, and here's the old bullet here. So the cause and manner of death? Well, it's going to be these infectious complications of his quadriplegia due to his gunshot wound, and it's going to be a homicide, even though this happened 20 years ago. Now, let's say that the same gentleman, instead of dying from his sepsis, he developed lung cancer and he died from his lung cancer. That would be an example of an efficient intervening cause. Remember our proximate cause, and that would take the gunshot wound off the table, and now it's a natural death. And these deaths do happen. They're not that common. This was a case that happened in Brooklyn where a person died 30 years after being shot from complications of that gunshot wound, and they rearrested the shooter. He's like, oh, no, wait, that straightened out 30 years ago. No, this is not double jeopardy. These are new charges now. Now it's a homicide. And I'll give you one more example of a cause and manner of death, and that would be for the Wicked Witch of the East. How would we certify her death? Well, she died from blunt injuries of the head and trunk, and I think it was an accident. I don't think Dorothy intentionally dropped the house on her, and she was crushed by a house during a cyclone, and it occurred at the Yellow Brick Road. Forensic pathologists practice in the finest tradition of preventive medicine and public health by making the study of the dead benefit the living. And that is it. I am available for any questions.
Okay, we have a lot of questions here in the chat. I don't think we'll get to all of them, but I guess the first one here is from Chris H, and he's asking what cavity, volume, or crevice is the most probable area to predict time of death? For example, is the bone marrow the longest period, and is it accurate?
Some people have done some tests, some cellular tests, looking at flow, cytometry. The organ that undergoes the earliest autolysis is the pancreas because of those digestive enzymes. But because we don't know the starting temperature of the body, if they have an infection, what's the environmental temperature. There's so many factors that it's very difficult for us to gauge on a cellular level. The organs undergo autolysis at different rates. So the classic ones are the rigor mortis, the stiffening of the body, which happens usually, within a few hours after death. It kind of reaches a peak and then it goes away in about 24 hours. You can measure the body temperature. The temperature changes about a degree and a half an hour. And then the lividity, the livor mortis, the settling of the blood, that develops usually over a few hours and becomes fixed in several hours. Unfortunately, the body, you really have to look at the circumstances. That's the best way to try and narrow down that window of the time of death. Yeah.
The next question here is from Ming Sung Liu. How does Connecticut's autopsy rate compare nationally?
Yeah, I think we end up autopsying about a little less than 1% of the deaths, or about 10% of the deaths, and I think that is kind of the level that you should be at. There are some offices I know. With the shortage of forensic pathologists, that they don't autopsy as many people. Some offices, for example, don't autopsy drug intoxication deaths. And in order to diagnose a death due to drug intoxication, you don't just need the tox results, you need to exclude other causes of death. If you don't do an autopsy, you're going to diagnose 10, maybe 20% of death. So there are some offices, some coroner offices too, that have much lower percentages. We are kind of where we are for national accreditation. We're kind of at a right level, about 3,000 out of the 33,000 deaths we autopsy.
The next question from Ming Sung Lu is also, what is your biggest pet peeve on how the medical examiner is shown on TV or movies?
I think the speed of the results, the testing. You get the toxicology, you get the DNA test back in an hour. Actually, there is now we do have this high speed DNA testing. Actually, we have one in our office. It's a little machine. We put a little cartridge in it, and we put our little drop of blood in it, and a little swab, mixture. And in about 90 minutes, we can get a DNA profile, believe it or not. So we're actually almost approaching television. Um, and more offices are using those. It used to take days and weeks before we get DNA back. Toxicology generally it takes weeks because there are very sophisticated testing they need to do. They need to not only detect something, but then quantitate it, confirm it. So usually it takes an average for us about 18, 20 days before we get the toxicology results back. So that's usually the big delay. But I have to say that I appreciate the television shows because it has exposed a lot of people to forensics that wouldn't have known about it before. And we're interviewing fellows now for our fellowship, and a lot of them, I say, where did you learn, learn about, forensic? Oh, on TV or a book. So I'm happy about that. I usually don't watch them. I do watch though The Pit. My mother told me to watch The Pit. I said, I don't usually. She said, watch The Pit. And The Pit is incredibly realistic. I mean, and it's, has you crying and laughing in the same episode. If you haven't seen The Pit, it's not forensics, it's, ER medicine, but it's really a very realistic show.
So the next question here from Kimberlyn Zinger, she asks, I guess she's referring to that case that you showed the person in the car with the sulfuric acid and the formic acid. Was that an example of accidental poisoning, or do people purposely mix those chemicals to commit suicide?
Yep, no, those would be suicide. So for a suicide, we have to show that the person intended to do this to harm themselves. So someone normally wouldn't mix those two chemicals to make, carbon monoxide to cause their death. The other one we see is lime sulfur and hydrochloric acid, which makes hydrogen sulfide a gas. That's another poisonous gas. But there are they're for suicide. And yet that was a suicide. Only about half the people who commit suicide will leave a note. So you do have to look for an intentional act on their behalf. And the fact that he mixed these two chemicals in his car is enough for us to call it a suicide.
Jay Sang has a question here about embalmers finding large clots pre-COVID with vaccine use, and he's asking, is that real or fake news?
We would see sometimes in the lungs when you have a very advanced bronchopneumonia, you can get some small thrombi in the lungs. You see that with sepsis sometimes too. So that's not unusual, but we see that with influenza too. I mean, it's there is there's some literature that maybe it resulted in a little more hypercoagulable state than typical influenza, the COVID did, and maybe resulted in some more deep venous thromboses and things, and pulmonary emboli. But we see these frequently in hospitals, in patients hospitalized for a variety of things. Just not being ambulatory puts you at risk for developing a blood clot in your leg.
Okay, Cynthia Klosky has a question. How did you manage the mental well-being during 9/11 and the COVID response?
Yeah, I mean, you're working with your other colleagues, and you do try and focus on the science of it. But it was challenging I'd say for all the medical examiners, even though we see terrible things every day. When you see it on that scale, it's difficult. They brought in people to speak with us, and they had other people set up for counseling and so forth. One of the doctors I worked with, actually a woman I did my fellowship with, her brother was a fireman. She didn't know if he may have been responding. So, she was a wreck. I mean, you can only imagine. And whenever a member of service came in, they would form a line. and kind of have an honor guard when they bring the remains in.
Okay, I think I've got time for one more question here. When it comes to toxicology, with all the analytical techniques, like HPLC, MS, and IC, which one is the most often used?
Um, for the expanded tox, kind of uh, time of flight, um, uh, GC or mass spec is the common one. Although, a lot of people think that, by doing toxicology testing, we detect every drug. We don't. We detect our typical expanded testing picks up over 200 drugs, common medications, drugs of abuse. We can do specialized testing if there's a certain drug or compound we want them to look for. Um, but there's no tox lab in the world that can test for, there are thousands of potential compounds out there, right? So we test for all the really common ones and alcohol and so forth. Yeah, GC or LC mass spec, and then the time of flight gives you a lot of potential information. That's getting a little bit out of my area. I mean, I kind of defer to the forensic toxicologists. They're kind of the experts in that. Forensic pathologists, we consider ourselves kind of experts in the interpretive toxicology. What does this result mean in this person? Did it cause their death or not?
Roy Oceano has a question here. I actually do have more time. Um, what do you think about AI assisting your time in finding conclusions in forensic pathology?
It's working its way in. There's been some use with autopsy reports. So, instead of having to dictate in your formal report, you can kind of list your findings, and then AI will put it all together into a nice report. That's pretty simple. There's been some things with maybe pattern recognition. In one of our last forensic meetings, someone had scanned in a bunch of hundreds of entrance wounds, entrance gunshot wounds, and exit gunshot wounds, and tried to train AI to see if they can, diagnose an entrance from an exit, which is something that can be challenging sometimes. And it did pretty well, actually. So there may be some uses in regular hospital pathology also for diagnosis, looking at tissue sections for cancers, and being able to have one more set of eyes, maybe looking at something that maybe a living person could have missed.
Mike Garrison has a question here. Do you ever work with anthropologists or similar skeletal experts on bodies that have been dead for a long time?
Absolutely. We actually have our own there's a forensic anthropology specialty now. We have our own, she's part-time, but we have our own forensic anthropologist in Connecticut. We get quite a bit of bones. Most of them are non-human. Someone finds a deer bone or something, but the police, they bring them in. And so our anthropologist is very helpful with those, as well as sometimes we do get skeletonized remains. And even in cases, for example, of strangulation, or we may have a fractured hyoid bone, we will save that and have the anthropologist also examine it and do a report. So they're involved. Another time when they may get involved, they're dismemberment cases. So a body may have the arms, the hands cut off. They can look at the saw marks, those tool marks, and say, was it a regular saw, a hacksaw, an electrical saw, things like that. So they can be very, very helpful. And there's a big growth in forensic anthropology now. They have their own society, their own certification, and they attend the forensic meetings with us. Yeah.
From Chris H. Does the viscoelasticity of the tendons decrease with time? Will they break at different rates?
I mean, the
Maybe
body
Chris
will
can ask that.
Yeah, I mean, after death, the body will undergo, both autolysis, kind of self-dissolving, and then putrefaction, which is a bacterial-driven process. We all have bacteria in our large intestine, on our skin. After death, your immune system's no longer working. Those bacteria start to proliferate, and the person gets to be bloated and green. And we call those autopsies job security, because no hospital is going to want to do autopsies on those. But that will weaken the muscles and tendons. As far as age, just in general medicine, I think, yeah, aging, I know people blow their Achilles tendon as they get older and so forth, but you may want to ask an orthopedic surgeon about that specifically.
Okay, and Scott has a question here. What cases are still difficult to solve today still? And is there any research at MIT or elsewhere that's impacting forensic pathology? Which research would you want to see happen?
Yeah, I think some of the sudden unexplained infant deaths. So there are deaths in infants, usually under 6 months of age, they'll just be found dead in the crib. Some of those, as we do more and more scene investigation and reenactments, some of those are probably asphyxial deaths, and they are asphyxial deaths where the baby's sleeping in an adult bed, maybe with pillows and things, and they asphyxiate. But there are deaths where we do a full autopsy. On baby deaths, we do the whole 9 yards. And if everything is negative, then we're really kind of stuck. We don't know why they died. And in some of those channelopathies I was talking about, we've started to look at infants now, those sudden infant death cases, and about 10% of those have been found to have these channelopathies. So that may be explaining some of that group. There's a group in Boston that's looking at serotonin in brainstem of these sudden infant death infants, and maybe it's a developmental issue with serotonin. So there is molecular and kind of basic science going on in sudden infant death syndrome, looking to explain why did some of these infants just die. I mean, they're healthy infants, and all of a sudden the parent goes to pick them up and they're dead, and we don't know why in some of those cases.
Okay, so we're at about time. That was a great talk. It was very polished, very thorough.
Thank you. Thanks for inviting me. I enjoyed it. I always love to share forensic pathology with people. So.